Hello, my name is Fred Trotter with CareSet Systems. I'm a healthcare data journalist, and today I'm streaming from Healthcare Datapalooza 2024. With me is Eric Ellsworth with, please
Consumers
introduce yourself.
Checkbook, Center for Study Services.
Right, say it again.
Checkbook. Consumers Checkbook.
Consumers Checkbook. I put in my earpiece here so I can make sure all of the audio is working. Say that again.
Consumers Checkbook. Am I not
all
close
right, there
enough?
it is. I hear the echo now. Thank you so much. We want to talk about medical necessity. Tell me.
Okay, so medical necessity is very deep in the healthcare payment system, but it's pretty fundamental to people's experience with care. When you go to the doctor, and the doctor's going to try to bill your insurance company for the services that you receive, which is how most of us get our healthcare paid for, at least parts of it that aren't in our deductible or copays or whatever, but an important part of it. The insurance company wants to know, mostly legitimately, that the service that the doctor's providing is a medically necessary service that's needed to treat your condition. So that's things like you wouldn't want to treat a migraine by doing a knee surgery. That's obviously not a medically necessary service. And unfortunately, in health care, because of the nature of the service, the only one that really knows the service that was rendered is the doctor. So there's got to be some rules that help, and there is fraud in healthcare, unfortunately. So there's got to be some rules that indicate like this doctor was a real doctor doing a real medical procedure that was needed. So the kind of foundational need for there to be something like medical necessity is real, but the way it's implemented right now is very opaque. And it kind of shows up in other discussions that you might hear about, like prior authorization. Prior authorization actually is an extension of medical necessity that just says, we want to know that it's medically necessary before you do the service. We want to evaluate that before you do it.
Because it's too hard to do afterwards for some reason.
Yeah, or they want to control that service. They want to check that it's needed because they feel like it might be being overutilized. The insurer does. The provider,
or they want you to use their provider, or
their provider is usually a distinct issue. It's more that you've seen a provider that hopefully that takes your insurance. That's always a little bit of a sticky wicket with provider directory problems, as you know. But the medical necessity part is this you're proposing to do? They like to control it when they think an expensive service may be being used when a less expensive one could be used, right? Do you need to do surgery, or should you just on this person's knee, or should you just give them a cortisone shot? Is the kind of thing that where the debate really shows up. So in any event, prior auth has been a huge flashpoint for providers. They hate it, right? And patients hate it too. And so
insurance companies hate it too. No one likes this.
No, yeah, but underneath that is a set of rules that are not especially well documented. And that's, so they tend, certainly from a consumer facing transparency person such as myself. Let me just give you a personal example. My daughter is type 1 diabetic. And so in order for me to figure out which insulin pump is covered, I have to find the medical necessity document, which sits inside some portion of the provider-facing portion of the insurer's website, right? So you go to providers.insurer.com, and you go look up in there and you look up, the condition that you are interested in. Now, the lookups are not that great because it might bundle all endocrine conditions together, right? It might put type 1 and type 2 diabetes in separate categories. It might, right? So there's no kind of standard logic or layout to those things. And then they're written for a doctor, right? So they'll say, if you want to have an insulin pump that does automated insulin, then the patient must probably meet certain criteria with respect to management of their A1Cs for glucose and, other kind of complex rules. And so for the providers, in order to actually figure out whether they should prescribe a pump, they have to kind of maintain awareness of some of these rules. And it can either show up in prior auth as they got to fill out the form before they do this and send it off to the insurer. And the insurer will evaluate a priori, the rule against the rules and say, yes, this is medically necessary. Go ahead. We will pay for the pump. The corollary to prior auth is if you don't do that, they'll never pay. Or if it's kind of what you might call regular claims processing, then they wait for the provider to say, we prescribed this, and then they approve or deny the claim, right? So for true transparency in shopping, you'd like to see that stuff available to consumers and available to providers in some organized way. So what I'm basically here to say is, I think, right. And then there's a third component of it that's a kind of policy component, which is who should be in charge of making that decision? Should it be the doctor? Should it be the insurer? There's some pros and cons on either side. I'd say the insurers are going to be mostly interested in cost control, and the providers are going to be interested in timely access to care. And, sub rosa, they're going to be interested in whatever makes them the most money. That's their businesses too, and they've got to pay their employees. And so there is a natural tension there. But right now we have a data set that's really, really opaque. So they live in, there's no standard structure for how they're exposed via websites. There's no standard structure for how they're broken into PDFs. There's no standard structure for how you might look them up, right? So I think as far as data sets go, it'd be a really interesting one to get out and compare and say, okay, United Healthcare covers these, this set of services with this set of rules under these conditions. And then, your Blue Cross plan covers it in a different set of rules in a different condition. So, and one more thing, I'm interested in your reaction, but one more thing that kind of goes with that is then you have an identifier problem. Like Medicare maintains different medical necessity rules because Medicare has a whole different arrangement around that, right? Because Medicare has an authority over those rules.
When you say Medicare in this context, you're talking about fee-for-service?
Either fee-for-service or Medicare Advantage. CMS is the payer, right? And in your employer insurance, there's a regulator, which is the Department of Labor, but it's a private company contracting with your employer privately. And then in the ACA, it's kind of in the middle. The part of CMS that runs the ACA is not really the payer. They're a subsidy provider with a private payer, right? Whereas CMS is paying for Medicare bennies, whether or not they're fee-for-service or Medicare Advantage, they actually pay for this person's insurance. So in Medicare, they have a much stronger and largely better arrangement for medical necessity rules. And also a kind of corollary to that is the coding rules. How do you code different procedures and services that you did? There are rules that each payer maintains that says you have to code a knee surgery this way. We don't accept these other codes. And in fact, if you don't attach the following diagnosis codes, your knee surgery claims are going to get denied because you didn't tell us that this was the right kind of knee surgery for the right kind of.
So let me ask you before you go on and before I react.
Yeah.
I convinced you to come on by saying you said to me, "Hey, can I talk about medical necessity?" I was like, "Yes, you can,"
and I did,
and you did. But before we go on, say why you care. What do you do at your organization? What is your organization doing?
Yeah, great.
Why does medical necessity matter to you?
So
besides your daughter.
No, personally it matters. I think at Consumers Checkbook, we have a long history of doing transparency in healthcare.
Consumers Checkbook, the website is
checkbook.org.
Checkbook.org.
Yeah. Okay. So, and we're also standing up checkbook.health as that relates to our plan shopping experience and some other provider shopping stuff that we've done. Checkbook.org is an all-purpose magazine for all service providers. We started that 40 some years ago to rate all kinds of service providers and learned that there was a great need in healthcare to provide information to consumers. And then we've carried that forward by doing plan shopping tools for ACA exchanges and the federal employees. And then also, you probably know us because we did a FOIA suit that to be able to publish individually identified safety outcomes about individual surgeons, right? Using Medicare claims data, thanks to a long FOIA effort by our now late founder, Robert Krugoff. So when we do these shopping, we do a lot of healthcare shopping, and that puts us in the position of wading through a lot of this administrative thicket, shall we say. And so in the end, what people are buying when they're buying insurance or going to a doctor is they want to get their medical problems resolved, right? So a lot of times, if you're shopping for a health insurance plan, you're doing it because your family may be managing particular health needs, and you want to know that your health needs will fit within that health plan. So that could happen to you when you change employers and the employer offers different insurance plans than the ones that you were in. It could happen when you're on the exchange. It could happen when you're a Medicare Benny and you don't like something about your plan and somebody says you should shop, right? And so why does it matter? It matters because that's, use a word that to me resonates and you can react to it. It's without that understanding of those rules, you don't have a line of sight. Right. So we talk a lot in healthcare shopping as though you could assemble all the things as though it were like other shopping. So in a car, when you shop for a car, you can basically say, I can assemble a whole bunch of information about car number one. I like the Honda Pilot. Right. I think I want an SUV. And then you can assemble a whole bunch of information about car number 2, all before you make the purchase choice. Right now in healthcare, you can't do that, right? You can't say, I'm going to go to this doctor and know what they're going to prescribe and what rules I'm going to face and what the final cost will be. And so, there is a lot of price transparency work. It's great. But in the middle of that is, what is the payer actually?
Yeah. So there's a shopping sequence problem, right? If I'm searching for a car or tires, or I'm choosing a grocery store, I get the information, then I shop.
Yes, exactly.
And then let's just say, be more specific than just shop. I get the information and then I make my choices. In healthcare, you choose your prior after you make your choice. Right. So it's learn, choose, pay.
That allows you to execute on your choices with payment.
That's right. And in healthcare, it is, I can't figure out what I don't know what doctor I can use because I have to choose my insurance. So I choose my insurance. Hopefully I've invested to figuring out what the insurance does or doesn't cover, but it doesn't really matter if I don't know what I need anyways.
Yes, exactly.
So I choose my healthcare insurance, which is a reputation.
Primarily brand. Yes.
Primarily brand choice, reputation choice, because I can't investigate the details of what I need. And then within that, then the payer helps me choose the provider because they have to be in network or it's totally unaffordable.
There's a whole set of problems with that.
Whole set of problems with that. Things that your organization is concerned with, and helps to solve both of those two steps, right? You have resources to help with that. And then after I've made, without the information I need to make a real choice, after I've already chosen, then I go to the doctor that my payer chose for me. And then that person gives me the advice. And then I'm in a position to say, I'm either going to get this treatment or I'm not. But the payment is already been made. I've already been under insurance for however much time I've been under insurance.
The terms of payment are set.
It's all upside down.
It's kind of all upside down. Right. And so, I believe a lot in consumer empowerment and choice. I think it's not obvious to me that we're ever going to arrive at a place where healthcare shopping is or should look like car shopping. But one other fundamental incentive structure that's in there is, remember that insurance companies don't send you a bill, doctors do, right? And so another residual problem for consumers is what they usually want is they want their medical problem solved. They go to the doctor because something is wrong, and the doctor is their agent. It's the doctor's job to say, here's what's wrong with you, and here's what I, as a reputable person, recommend that you do to solve this problem. And I think, we have a good, strong clinical credentialing system in this country, and most doctors are giving you reasonably good medical advice. It may not work for you, but on the whole, I don't think
it doesn't mean they were wrong to give you that advice.
Yeah.
There's a lot of variation about what works and what doesn't.
Yes.
A person can give you advice that doesn't work for you.
Yes.
And that's still the clinically right thing to say first.
Yeah. And I would say those are the kind of debates where you could say, yeah, I think one person's better than another, but I'm saying it's not like this one, like the doctor's going to give you something just that's total fraud or quackery.
Very unlikely.
It's very unlikely, right? It's just that it might be wrong, or it might have some incentives in it that are not the greatest for you, and it might assume things about your circumstances that don't apply. But but you're right. Then remember that when you enter the doctor's office, you signed a financial obligation form that says, I agree to pay for what this doctor does for me. And that confers, and what you're actually paying is you're paying whatever the insurance company doesn't pay. You bind yourself to that, right? If the insurance company says this doesn't meet medical necessity, you've signed a form that says you're responsible for payment of that. That's how the health system works now.
So let's imagine this is a process. It's kind of a flow of patients, a flow of the basic economic way our country works. You're saying very late in the process, medical necessity, after, in many cases, all of the issues about what is or is not approved, you haven't paid attention to them. Now the stream divides very strongly. And if your medical necessity is approved and your insurance company is paying for it, you have one experience. If they don't, you're having a very different
experience. You will owe the provider money for the uncovered services. That's the basic agreement that you signed is, when you sign that financial agreement, it's saying we're going to bill your insurance and we're going to do our best to get paid by your insurance. And most of them do, but you're responsible for anything they don't pay.
So, this is by the way, I should tell the audience, we talk a lot.
Yes.
So I'm sure there's 6 hours of conversation that we can have around this topic.
Yeah.
But I want to have one question that we do actually say on the stream, because I think it's just so interesting to see what you think about this. And it's a conversation that we couldn't have had a year ago about the same topic. If I take an AI system and and let's say the AI in 6 months, just as, again, another detail for the streams, as of this 2024 conference, AI has a little bit of trouble reading longer documents. It'll like pay attention to the beginning, pay attention to the end, and miss details in the middle. But very soon, the AI will be good at consuming a corpus of documents. Is it going to be possible in as a strategy to turn what is an amalgam of very opaque, very confusing, arbitrarily organized differently in every health insurance program there is, to throw that into an AI and turn it into a structured data set that says, let's say, call it on a per diagnosis code basis. Here's the diagnosis code. Here's how this, and then, or let's say, instead of just diagnosis code, here's a diagnosis code. Here's a corresponding treatment coded in HCPCS or CPT code. We're talking about the codes we typically use to do diagnosis and treatment in healthcare. And then using that as a way to organize what can be done by the healthcare system, to attach to it some, let's call it a bullet list of here are the things that United is going to say is required. Here's what Aetna is going to require for medical necessity and other things. Is AI going to make the data set we want here, or could it?
It could. So there, to answer that question, remember that there are the rules as stipulated in a written document, and there are rules as executed inside of software that runs the claims. So, and what we're thinking.
Well, before you keep going, what's the difference in implicate? When those differ, what does it mean?
Probably the interesting thing is, practically, as the claim goes through, it will obviously see the rules in the claims processing software. In terms of the law, I would not be 100% sure, but I'd bet that the written document is binding. So to the degree that to get there, you have to know that such a difference existed, and there's a constant problem with any sort of claim denials that people just don't know what really happened, right? They don't know the difference between a denial or why the denial happened. We talked a bit about this in our response to Medicare's data RFI, and so they're really lacking enough information to even chase down the nature of that problem and say to the insurer, hey, wait, your document says that you should be paying for this, and your claims are saying that you're not. So if they're really diligent and good, maybe they have good legal help, they can get to that point. Another thing that's happening that is in the positive sense is that the CMS pushed out a rule that is a good rule that requires automation of the prior auth process by insurers. And inside of that, prior auth, as I said before,
when did that come out?
It was finalized this spring. So inside of prior auth is the same medical necessity criteria that run under any circumstances, only the prior part is saying you need our approval in advance or we'll never pay the claim, right? Whereas the typical application of them is post hoc. So that rule is good because it's now inside of FHIR. There's something called coverage requirements discovery that I think can and should be leveraged to make the standard medical necessity criteria accessible via machine readable form. So it'd be nice to also do like, I like the AI idea that you're describing, that just gathering those documents would be so burdensome that I think, the AI part is the latter half of it. The first part is, how does each provider store them? Sometimes they just say, these are proprietary criteria that are offered by a vendor, and so you got to go buy them or something. It's a little, you should be frowning a bit. There are cases where they licensed proprietary criteria for medical necessity because we're too small. We don't have our own team to decide all the services that shouldn't be covered and all the new technologies that shouldn't be covered. So we're going to go to a third party, I don't want to name names because there's not a lot of them, but they go to a third party who does
don't name names too. We want to protect the guilty for the purposes of this particular stream.
I don't know. I mean, it's an existing, there's a few incumbents and so, and along the way, I think if you talk to providers, they hate this, right? This in some ways, this is taking the decision about medical necessity away from them, right? Because most medicine is nuanced, right? There's the part of it that's obvious, and here's the lab values, and here's the thing that we found on the scan, and I checked for the presence of these symptoms, or I palpated the patient's belly and found the following thing happens. And then there's the part that's like, oh, wait, this person is living on the floor of their parents' house. So I got to do something now, right? That's really, so shows up in the social drivers of health conversation, but it's still pretty vague on the insurance processing side for them to be able to say, oh, yeah, we should really just pay for this right now because this patient is in a bad way.
So let me ask you, I think this is the kind of thing where there's probably 3 levels of magnitude here. If you find your ship thrown against the rocks of medical necessity, it feels like, and I'm just intuiting this, I want to see if you feel like it's correct. And I also want to know if you think that data would be able to give us more information about this, or if you've been thinking about this. But if it's a small amount, let's call it under $1,000, $5,000, the average person will spend more than $1,000 or $5,000 figuring out how to solve the problem that costs $1,000. So there's a low level version of this where it's just like, I hit the medical necessity rocks and I eat it.
Yes.
Then there's another level where maybe you get the doctor involved, maybe you hire a patient advocate, maybe you like somebody else, probably all the way up to $100,000 ish.
Yeah.
And then over $100,000, you have to have these issues solved. You have to have a lawyer.
Probably, yes.
Right. So, and those aren't hard lines, of course. And I'm kind of arbitrarily talking about where the lines are, but do you think that you have a better picture of that? Is there data about what I'm talking about? Like when these happen, or how do we know these things? Is there any transparency at all?
So I think this is one of, we've talked on other occasions, and I don't know who's watching me knows about what happens in the event of a denial, right? But the way, I would say there's a number of, generally your conceptual framework makes a lot of sense to me. I think this is how people react to medical bills is if they don't have an obvious reason to know what's wrong and it's small enough, they're just going to pay it without knowing for sure that it was right. And there's a lot of problems in the billing practices like global billing by providers that make it really hard to figure out that this has happened, right? One service was under your deductible, another one was denied, and you get a global bill that rolls those together. As you say, people who, most people just can't figure it out. They have no information. They don't know the system well enough. I'd love to see a scenario where those bills had more information and you could go back and, there'd be like, hey, here's why we're billing you this piece because your insurance company did or didn't pay this. And, so there's a kind of related problem of the way that the bills and the explanation of benefits flow to the patients that makes it really hard for them to understand when this has happened. In the a posteriori, after the fact billing scenario, which is the common one for most people.
Eric, we've talked too long. We wanted to have a 15-minute. No, this is a compliment. You have so many interesting things to say. Every time I talk to you, I feel really good that there is someone who is as focused on these details as you, who's generally advocating for patients, because it's very, very easy to feel overwhelmed by this complexity. And if someone wanted to read more about your work, where would they find it?
Checkbook.health.
Checkbook.health.
Yeah,
we'll start to reveal
there, but we're moving forward on adding more about this kind of stuff. If the level of detail here was good, you're going to like what it's all detailed stuff.
Okay.
Yeah.
All right. So, Eric, thank you.
Yeah, great. Thanks so much, Fred. Pleasure chatting.